Welcome back, everyone, to The Explainer. Before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, today we're taking a seriously fascinating journey. We're going to uncover exactly how a single clinical encounter, a patient walking into a hospital, getting treatment, and being discharged, transforms into a standardized, highly regulated hospital bill. It's this incredibly complex translation of medical reality into statistical data, and understanding it is absolutely critical for the financial health of literally any healthcare institution.
So let's get right into it. Here is our roadmap for today. We've got 1. The DRG ecosystem. 2. Cracking diagnosis codes. 3. The IPDRG grouper logic. And 4. Documentation and revenue integrity.
Section 1. The DRG ecosystem.
Now, this ecosystem is basically the foundational framework that dictates how hospitals get reimbursed under Medicare's Inpatient Prospective Payment System, or IPPS. To really get it, you first have to understand the IPDRG, which stands for Medicare Severity Diagnosis-Related Group. I want you to think of it kind of like a massive statistical sorting hat. It takes the thousands of possible diagnoses a patient could have and the thousands of procedures a surgeon might perform, and it lumps them into roughly 750 distinct payment categories. The whole idea here is that patients who fall into the same IPDRG share similar clinical characteristics and, logically, are expected to consume a similar amount of hospital resources based on just how sick they are.
Moving on to Section 2. Cracking diagnosis codes.
Okay, so now that we know what these groups are, how do we actually get patients into them? Well, we use the literal language of medical coders. Here in the US, for diagnoses, that language is ICD-10-CM. These codes are alphanumeric, they can be up to 7 characters long, and they're organized superlogically into 21 different chapters based on body system or disease type. But here is the real secret to accurate coding. Every single letter and number carries a highly specific clinical meaning. The characters tell us the category of the disease, the etiology or root cause, the severity, and even the laterality, like whether it's on the left or right side of the body. For a claim to actually get paid correctly, it requires the absolute maximum level of specificity. You can't just slop pneumonia on a chart if the record actually says pneumonia due to Staphylococcus aureus. It just won't fly.
Now, for the procedural side of the coin, we use ICD-10-PCS. While CM is for diagnoses, PCS is strictly for inpatient procedures. And man, look at that rigid 7-character architecture. Each position has up to 34 possible values, and they all have to be filled in. The first character is the section, second is the body system, third is the root operation, think excision or bypass, and that's followed by the body part, the approach, the device used, and finally a qualifier. It is incredibly precise. If a surgeon forgets to document whether an approach was, say, open or percutaneous endoscopic, the coder literally cannot build a valid code. Before we jump into how these codes get grouped together, we really need to clear up a massive distinction that trips people up all the time. There is a huge difference between the primary reason for admission and the principal diagnosis. The reason for admission, that's just the day one presenting symptom. Like, let's say the patient comes in with severe chest pain. But the principal diagnosis is the condition established after study to be chiefly responsible for the admission. So after running all those tests, that chest pain might actually turn out to be an acute myocardial infarction. And here's why that matters. It is the principal diagnosis, the acute MI, that actually drives the DRG assignment, not that initial symptom.
Which brings us to Section 3, the IPDRG grouper logic.
All right, so we've got our precise diagnosis and procedure codes. Now let's step into the engine room and see how they actually interact. The grouper is this really complex software logic engine, but we can break its workflow down into 5 basic steps. Step 1, the engine reads that principal diagnosis we just talked about, which sets the base major diagnostic category, or MDC. Step 2, it scans all the secondary diagnoses looking for complications or comorbidities. We call these CCs and MCCs. Step 3, it checks for any major procedures, which can actually bump the patient from a standard medical DRG to a much higher-paying surgical DRG. Step 4, it factors in demographics, age, sex, discharge disposition. And finally, Step 5, the engine spits out the final IPDRG. This generates a specific relative weight that tells the hospital exactly how much they're getting paid. Let's actually look at the real financial impact of this severity using a classic IPDRG triplet for heart failure. Check out that bottom tier, DRG 293.
That's heart failure without any complications, so it has the lowest relative weight. But if a coder correctly identifies from the medical record just one major complication or comorbidity, an MCC, like say acute renal failure, boom, the engine bumps the case way up to DRG 291. Capturing that single MCC directly scales the relative weight and can dramatically increase the hospital's reimbursement, simply by accurately reflecting how sick that patient truly was.
All right, Section 4, Documentation and Revenue Integrity.
Let's bring this all together by looking at the real-world financial stakes here. I want you to think about something. What happens if a patient comes in for a routine surgery, but then they develop a major life-threatening complication like deep vein thrombosis or sepsis after they've already been admitted? Does the hospital still get to claim that higher DRG weight we just looked at?
Well, the answer comes down to the present on admission, or POA indicator. Every single diagnosis code has to carry a POA flag, either Y for present or N for not present at the time of admission. And the ripple effect of just that one letter is huge. Medicare has some very strict rules for hospital-acquired conditions. If a severe condition like that DVT has a POA of N, meaning it happened under the hospital's watch, it generally cannot be used to increase the DRG payment weight. Actually, hitting the hospital with a bundled payment penalty is a very real possibility. So yeah, quality of care directly, literally, impacts revenue.
So the big takeaway here is that hospitals have to walk a really tight ethical and financial line. On one side, you have upcoding. That's assigning a higher level code than the clinical documentation actually supports. This is a massive compliance risk. I'm talking legal action under the False Claims Act and severe payer audits. Bad news. On the flip side is undercoding, assigning a lower level code usually because the physician's notes were just too vague. Undercoding causes immediate, unrecoverable revenue loss, and it artificially lowers the hospital's severity metrics.
To avoid both of these extremes, hospitals rely on Clinical Documentation Improvement, or CDI teams. Here's a great example of how they build a bridge between doctors and coders. When a physician writes something vague, like just respiratory failure, the coder is basically stuck. But a CDI specialist will proactively send a query, looking exactly like this. Doctor, please clarify if the documented respiratory failure is acute, chronic, or both. Getting the doctor to officially update the record to acute respiratory failure might just be the exact MCC they needed to secure the correct, legally compliant, and higher-weighted MS-DRG. It's a total game changer.
So I'll leave you with this thought to chew on. Is your clinical documentation really telling the whole story, or are you leaving revenue and compliance totally up to chance? Precision in healthcare isn't just about the scalpel, right? It's about the pen, the keystroke, and the code.
If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding, keep learning, and I will see you in the next explainer.